The opinions expressed by the host and guests in this show are not necessarily the views of Children's Health Defense.
Good morning, CHD. It is Monday, June the 1st, 2026, and we are going to be talking about hepatitis B today. The war around hepatitis B is still on and forth. So let's get some headlines up to start with. And this is the World Health Organization, and it says vaccinating her is the most important thing I can do to keep her safe while she figures out the world. So that's from someone called Ola in Denmark. That's ridiculous. Gavi, the Vaccine Alliance, this just in. 2 new studies in JAMA Pediatrics confirm that the Hep B birth dose is the strongest shield a baby has against lifelong chronic infection, cirrhosis, and liver cancer. So that, I think, is, let's bring on Dr. Suzanne Humphries to discuss whether that is a true statement or not. Good morning, Dr. Suzanne Humphries.
Good morning, Polly. How are you doing?
I'm fine. I'm so pleased you're here because there's no one better than you to put things straight. So let's get into this and talk about, is hepatitis B a good idea for a newborn baby?
Yes, indeed. Well, I find these headlines highly amusing, and I'll get to the point of what figuring out the world, because I find that particular comment highly ironic. Which tells me that they have absolutely no clue, or they're just willfully ignorant about how an infant immune system is actually designed and programmed to operate and develop. And we'll talk about the strongest lifelong shield, and because they act like if you just give that baby that one shot and the 2 follow-ups, they're set for life. Well, guess what? No, they're not. They're going to be told to get hepatitis B vaccines over and over again throughout their lifetime, more and more aluminum over their lifetime, more hepatitis B antigen into their body. So anyway, let's get started here. So my first image here is the World Health Organization one that says, ensure babies get at least 3 vaccine doses. And why do they say that? Because sometimes they give 4 if the baby's premature within the first 24 hours after birth. And ideally, I think they say within 6 hours. Can you even imagine? This is what they're doing. So the first image there you'll see is a little schematic of a virus particle. And so let's talk about what hepatitis B virus actually is. What it is a double-stranded DNA virus that primarily infects the liver, although you can actually detect it in blood as well. But where it causes the damage is the liver. And so we have acute and we have chronic hepatitis. So acute is when you're first infected and you may have signs, you may not. But guess what? Here's something interesting. Adults have mostly reversible injury to the liver, and the immune system usually wins the battle. And most adults clear the virus completely within 6 months with full recovery and minimal or no lasting liver damage. And only 10% of infants exposed at birth recover completely on their own. So there is a difference between adult infections and newborn or childhood infections. And there's a reason for that, which we'll get into in a minute. And then there's the chronic hepatitis. And these are the people that never do clear the virus. And it kind of smolders inside the liver and it causes inflammation. And then it can cause scarring and cirrhosis. And yes, a small portion of those people can end up with some liver cancer. And this is a big concern, and this is why they, at least why they state that they push this vaccine on babies at birth. But why they push it on all babies is really my bone of contention right here. And so we're told that vaccination, this is another thing, that we're told that vaccination absolutely prevents both phases of acute and chronic hepatitis, and that's absolutely categorically not true. 5 to 10% of adults will be non-responders to the vaccine. In my experience, it was even higher than that in kidney failure patients, dialysis patients. Some of them we would vaccinate with 4 rounds of hepatitis B vaccine before we were told that we should tell them, yeah, we probably shouldn't do this anymore because you're probably a real non-responder. And I actually had a colleague in Maine who was a young man, very healthy, and he had to have 4 rounds before they finally gave up on him. And he was not very happy about it. And so they cite the same number, 5 to 10% of infants born to hepatitis B positive mothers will not respond to this vaccine, no matter how many times you give it and no matter how aggressive you are with this situation. So next, I just want to show some pictures. And because we have some people out there who like to make fun of the hepatitis B virus, they like to say that it's all a bunch of jiggery pokery on the screen when the images are shown. And so early on, I guess some of the pictures were a bit primitive, but in 2019 here, you can see there's an article by CAO, C-A-O, and it's entitled Electron Microscopy Structure of Native Spherical Subviral Particles Isolated from Hepatitis B Virus Carriers. And the next image shows you what they captured there. And yeah, so if virus deniers have some kind of problem with what I'm talking about in this lecture, I would like to refer them to this guy, because I think the conversation would be very interesting to have between these groups of people and the virus deniers. Leave me the hell alone, okay? Because we've got some data here that we need to talk about, and we're going to talk about it. And the next slide here is just another study by LIU, and you can actually look at this one online, where the previous one I actually had to pay $27 for. This one is actually free. And this is one where human blood was examined the same way as the previous one. And they also looked at a woodchuck hepatitis model. And I just want to say that the virus deniers will say, oh, you know, they cause these particles to form by the processing that they do in the in the workup to look at it in the electron microscope. Well, I looked up what the process is, and they basically put it in like a sugar buffer, and then they centrifuge it on beads, and it's separated out by weight, and then they stain it, and then they view it. So there's not antibiotics and chemicals or anything like that going on here. And they like to say that this is all just toxicity from various things. Well, I wish that were true. I wish what they say was true, because it would mean that, that we could just get over this whole vaccine myth really quickly, but we can't. So the image after this shows you the actual pictures that they took with isolation of hepatitis B virus subviral particles and analysis by cryo-electron microscopy and 3D image processing. And they also characterized it genetically. So again, go talk to Kevin McKernan, go talk to these scientists. Here's the information. And I believe that hepatitis B is a real thing. But look, is there corruption in virology? Is everything that the virus hounds say true? No, it's not, because as we know, most people get over hepatitis B virus just like polio, and they never even know that they had it until they get a blood test later and somebody looks. But with babies, it can be quite significant. So, what are the symptoms in acute hepatitis B infection in infants, children, and adults? Most people will experience few or no symptoms. 65% are unaware that they carry the virus. They might have just had a real severe nausea, vomiting episode in the past where they didn't turn yellow or anything like that. And then 30% of people with acute hepatitis have no symptoms, and fewer than 10% of the 90% infected, exposed newborns have any symptoms. So the newborns that are supposedly getting it from their infected mothers also won't have symptoms, at least at first. And if there are symptoms, usually you'll see this in adults, but you can see it in really severe infections in very weakened, toxified babies. Fatigue, fever, malaise, nausea, vomiting, yellowing of the skin, jaundice, loss of appetite, abdominal pain, bloating, indigestion, headache. It sounds like an ad for a drug company, doesn't it? Okay, so before there was a vaccine at all, we have to think about what was going on back then. So low-risk births in mothers who were tested negative, there were no infections. That's a really important point. So low-risk mothers who tested negative did not pass anything on to their babies, even before a vaccine was available, okay? And we're told that 16,000 to 18,000 children were hepatitis B positive per year. They're noting this before the age of 10, and half of them were infected at birth. And I want to be clear here. And, a lot of people make fun of AI, but I really love AI because, I can sit there and just fire question after question after question. And I was thinking about this and I was like, well, how do they know this? Like, how do they do these measurements? They're not measuring a whole bunch of newborn babies and a whole bunch of toddlers. They're not checking blood from them. No, what they do is they do this, what's called epidemiologic modeling. And you can go and look for yourself what that is. I don't really have time to explain that, but it's not actually direct measuring of different populations. It's extrapolation from some measurements from different databases. So the non-Asian estimates were about half of that number. Okay, so you have to remember that where this all got ramped up is that hepatitis B is pretty much endemic in a lot of Asian countries and also in Alaska. And I think we need to do a completely separate talk on that, because what we're told about why it's endemic in those countries, in my opinion, is a total lie. I think that it was introduced into those countries through various means, nefariously and maybe accidental, black market syringes and things like that. But I don't have time to get into that today. So there are about 9,500 infants per year in the USA infected at birth before a vaccine. So that translates to about 240 per 100,000. But if we want to look at the non-Asian low-risk population, it would be about half of that, right? And the risk of a false negative test in the mother is so small that it's not really even a contributing factor. But if the mother's a drug abuser or sexually promiscuous, then obviously you want to retest before birth if you had a negative test before, because there is a window period and there are some caveats with the testing. Okay, so what's the worst case scenario? The worst case scenario, if there's no intervention and there's no test. Well, high-risk mothers are about 0.5% of the population, and the worst-case scenario would be 400 to 500 babies per 100,000 born to hepatitis B positive mothers per year getting exposed. And if there's no treatment to the baby, but the mother has a low viral load, and we can test that with the hepatitis B E antigen, but if the mother has a low viral load, there's 10 to 25% chance she'll pass that to the baby. Right? If there's no treatment to the baby and the mother has a high viral load, then it's estimated 70 to 90% will pass it to the baby. And remember, these are estimates, and look at those wide margins in these estimates. So, but it's not zero. So for any infant infected, 90% of the ones that actually do get infected can go on to have chronic active hepatitis. And they make it sound like it's an absolute death sentence. But the reality is that 25% of that 90% could go on to die at the age between 40 and 70. So not all babies born to infected mothers will become infected, but it is a relatively high number. So let's break down the numbers a little bit further here. If we have, as they estimate with their modeling, 18 to 25,000 infants born each year to mothers who are hepatitis B positive, all those babies are at risk, right? But only 7,000 to 10,000 would become infected, because there's an average, if you average out the high risk and low risk, of about 40% transmission to the baby. Of those, 6,500 to 9,000 could develop chronic hepatitis. And 25% of those, 1,625 to 2,250, could go on to die between ages 40 and 70. So all in all, 9% of all infants born to hepatitis B positive mothers could go on to die of hepatitis complications later in life. And the other reason given for vaccinating the newborns is that there's concerns about contagion from those babies that are carriers, because they will be carriers for quite a long time if they don't clear the virus. So that's the real numbers. Not that every baby born to a mother with hepatitis B is going to immediately die or develop cancer at an early age. It's still not a good situation, but it's not as dire as they pose it to be. So I'm just here to give the reality. I'm not here to take sides, although I know what I would do myself. I've actually been the victim of 4 hepatitis B antiviral vaccines in my career before I knew better, and I have to say it did me no good as an adult. All right, so with testing of mothers, which is what we do, let's think about that. So if we have 18 to 25,000 babies born each year to mothers with hepatitis B, and we have estimated that 800 to 1,200 babies born with hepatitis B, despite screening and hepatitis B immune globulin and vaccination is a reality, that 720 to 1,080 babies could go on to have chronic active hepatitis out of those 18 to 25,000 babies. But testing of mothers and aggressive prophylaxis in infant will bring that number down from 9,000 to 1,080 babies. So it does apparently, per the modeling, decrease the rate of chronic active hepatitis if there's aggressive prophylaxis. And what that means is that they vaccinate them within 6 hours of birth, and they give them a human plasma immune globulin injection. So I think it makes sense to test mothers and try to reduce the suffering of the child early on and later. But we should understand that even with testing and even with the most aggressive measures taken to that baby at birth, that a significant percentage of them are going to fail to resolve the infection. So if a mother is truly hepatitis B surface antigen negative, guess what? There is zero risk to the infant. 0.0 risk to the infant if the mother is truly hepatitis B surface antigen negative. Now, what I mean by truly, well, there can be some exceptions. The mother could become infected after the test is done. Infection after the birth by the hospital or by another family member could occur in that child. There could be a false negative blood test on the mother due to a hospital error. It's extremely rare. There are vaccine viral escape mutants that have happened because of the vaccine pressure that's been put on, and that's been documented since the 1980s. And then there's that window period where there's an infection, but the test doesn't actually show up yet because the process in the immune system hasn't fully developed. And there can be a very, very low viral load in the mother, of which I noted earlier that the risk of passing that on to the child is even lower. But when there is doubt, retest the mother before the birth. It's simple. I mean, you can literally get a blood test while she's in labor, so the chance of her having sex or shooting up while she's in labor, really, really super low. So why are babies more prone to be carriers and develop chronic hepatitis than adults? Well, there's a reason for that. So the infant immune system. So remember when they said that we have to give this hepatitis B virus to the baby while she figures out the world? Oh my goodness! Like that's really hard for me to tolerate, knowing how the infant immune system works. So the infant immune system, and I've gone through this in my infant immunity series, which maybe I'll give that link to Lou to put up, because I've very well characterized what is very well known about the infant immune system in mammals and in all humans, is that it's inherently biased to be non-responsive and immune tolerant as it is developing, okay? While she's figuring out the world, her immune system is supposed to be quiet and non-inflammatory, because it is actually more important for that baby's immune system to know what not to react to than it is to know what to react to. Because the fact of the matter is that anything invasive will at some point be reacted to. So a serious bacterial infection, that baby will react. But it's not a good situation. You don't want to stimulate that immune system. So it's not actually a deficiency in these newborns. They are, by design, given a low Th1 cytotoxic response. Also, the virus does not directly harm the liver very much. So it's not like a measles virus that is directly toxic to cells, okay? So it basically doesn't harm the cell. A little bit it does, but for the most part, where the damage comes in, it's the immune system that attacks the infected cells, and that's what does the liver harm. So babies don't react to this virus, so the virus can persist. Whereas adults, especially unless you have AIDS, adults will react to it. But these babies, non-reacting, can just lead to a slow kind of smoldering destruction of the liver over decades. And eventually the immune tolerance phase supposedly converts into a more immune active phase, they say around puberty or adulthood. I don't know. I mean, look, I'm just reporting what I read, okay? So the aluminum in the vaccine is supposed to override the natural quiet state of the infant immune system, and it forces it to go against the normal program. That's why aluminum is put in the vaccines. If you don't know, it's not a preservative. It's actually put in there to pretty much light the immune system on fire so that whatever antigen you put in with it will have a response within the immune system. Okay, so what are the reasons given for vaccinating babies? Well, if you don't know the risk, they say, go ahead and vaccinate. So if you have a mother just show up on the doorstep and, dumps a baby out and you don't know her history at all, I suppose, then they say, go ahead and give the vaccine. That doesn't really happen in real life, maybe very, very rarely. When other members of the household are hepatitis B positive, they say that infection into that baby could later occur. And then there's this whole daycare and school settings, and they say that, children are scratching and biting each other and that they're transmitting hepatitis B. And I think it's rather ironic that we are supposed to take that as a really serious issue, because there are a couple of case reports out there of that supposedly happening. Whereas when I used dozens of case reports to show that influenza vaccines were causing kidney failure, I was told, oh, those are just a few case reports. You need to do your own study. So you can see that case reports only matter when the pro-vaccine are using them. But nonetheless, these are the reasons that they give to vaccinate the newborn. But we always have to consider the risk to potential benefit ratio. And that's what this talk is really about. And I want to ask the question, is it worth vaccinating every baby in order to prevent infection in these rare circumstances? And by the end of this talk, you should be able to answer that for yourself, and you should have enough knowledge to be able to talk to the ignoramuses in the hospital that are pushing your zero-risk baby to have a aluminum-containing hepatitis B vaccine. So let's just reiterate again. If it's a low-risk mother, meaning she's not a prostitute and she hasn't been doing drugs, and she tests negative for hepatitis B, there is zero risk to that infant. We can't even get an estimate of how often it happens because it's essentially never. All right, so what were the estimated hepatitis B carriage rates pre-vaccine? This was kind of an afterthought I had when I was doing this research. Well, between the ages of 6 to 19 in the pre-vaccine era, hepatitis B carriage in the US children was very low in the general population. It was around 0.2 to 0.24% for the ages of 6 to 19. And this was from a big study that was done between 1988 and 1994 where they got this information. So I queried, well, what was the rate from birth to 6 years? Because this is really what we're talking about here. A chronic carriage before the vaccine was brought in was very low in the broad US population, likely well under 0.2 to 0.3% for birth to 6 years in low-risk groups. Most cases were concentrated in high-risk households, foreign-born from endemic areas, infected mothers and siblings. So in very low-risk populations, the estimation is more like 0.1% between the age of birth and 6 years were testing positive for hepatitis B. All right, so the ACIP is supposed to be an independent advisory board, but in the past we know that there were a lot of conflicts of interest. Even though they're not supposed to have any conflicts of interest, we can use Paul Offit as a great example. And in 1991, they recommended the hepatitis B vaccine to be administered within hours of birth to all newborns. Why? This was based on the epidemiologic modeling that I told you about in previous slides. So vaccinating all these newborns is said to have dropped the chronic carriage rate from a very low rate, like 0.1 to 0.2, down to a rate that is supposedly near zero. So that's what we're talking about. We're not talking about 50 to 70%, infections that have been brought down to nothing. We're talking about 0.1 to 0.2% of children that test positive brought down to zero, supposedly, if you give this vaccine in infancy or birth when the mother is strongly positive. So what is in the vaccine? What is the vaccine? Well, we have a couple of different ones, right? So let's first talk about the Engerix vaccine from GlaxoSmithKline. And this one contains 10 micrograms of antigen. And it is made on yeast cells. Now, remember, the original vaccines were actually made from pooled blood donors that were hepatitis B positive, and there were a lot of problems with other adventitious agents in that. Some AIDS was spread during that era, and they also used to have a mercury, thimerosal, and aluminum in those vaccines as well. But in terms of the antigen, it's exactly the same as it used to be, but today, instead of taking the pooled blood of gay men in front of bathhouses, we are taking it out of yeast. These yeast are programmed to produce the antigen. So we're going to have some residual yeast protein of about 5%. It has aluminum hydroxide, and it contains trace amounts of formaldehyde. But on this particular vaccine, it's not listed as an excipient, even though it has it. And this is supposed to be given on day 1 of birth to hours-old newborns if they're premature. There will be 3 or more injections in infancy or childhood if that baby's immature, because they say that that first vaccine doesn't count. In low birth weight infants, the day of birth vaccine never counts towards the schedule and will still be given at 1, 2, 3, and 6 months for those high-risk babies. In normal birth weight infants and otherwise low-risk infants, that first jab does count towards the total of 3 vaccines, but they're usually given 4 anyway. So the other vaccine is from Merck, and it is called Recombavax, and it contains 5 micrograms of antigen. And when I queried why does the previous vaccine from GSK have 10 micrograms and the Merck one has 5 micrograms, and how can they be considered comparable? I'm told just because they are, because that's what the application of the FDA used for each one of them, and they were both accepted, and they're interchangeable, even though one has more antigen than the other. Okay, whatever. So what I find really interesting about the Merck vaccine is that it actually contains 7.5 micrograms of formaldehyde, which is greater than the 5 micrograms of actual antigen that's in the vaccine. Yet we're told that none of that matters because your own body makes formaldehyde and blah, 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 blah. We've heard all the arguments against the injection of formaldehyde into any human being. So aside from that, it's pretty much the same, although there's a different type of aluminum. And the initial vaccine and still uses amorphous aluminum hydroxyphosphate sulfate. I think it's called AAHS. And that's the same adjuvant that's used in the HPV vaccines, which I've done talks on why that's so much more dangerous than the aluminum hydroxide vaccine, at least in the HPV vaccines, it's been shown to be. And I covered the difference in my talk that's titled Merck's Dirty Little Secret, which is on my Odyssey channel. But when the vaccine, this is interesting, when the vaccine was first released, it was labeled as having aluminum hydroxide, okay? The type that GSK has. But later, when it was determined that it didn't have aluminum hydroxide, it had AAHS, the label was changed without having to do any testing on the AAHS. So again, Merck lists 15 micrograms per ml of formaldehyde, which translates into 7.5 microgram injection into that newborn baby of formaldehyde, higher dose than the antigen. But we'll be told that it's completely different. It doesn't matter weight for weight, that one is more than the other because it's just so small. Okay, so next, let's just look at these Infenrix hexa. Because this particular vaccine covers 6 different diseases, and it's given at 1 to 2 months as a 3-jab series. So most babies will wind up getting 3 of these beautiful shots for a total of 4 hepatitis B vaccines if they got their first one at birth, right? Because they want to be able to get all those other antigens into them later. So that will be, okay, so you're getting a little hepatitis B. Oh, no big deal. All right, well, who can be vaccinated? Can you just vaccinate anyone? Can you vaccinate a child that's on antibiotics? Yep, you can. Apparently, it's no reason not to give it if the baby's sick and is on antibiotics. If the baby's low birth weight and preterm, no problem, just do it. The Red Book has all the details on injecting low birth weight infants, and that there's barely ever a reason to not give any baby this vaccine. And you can go look for yourself right there. And we know the infamous theory by Paul Offit, who has been quoted as saying, when challenged about how many antigens is given to a baby, he says that each infant would have the theoretical capacity to respond to about 10,000 vaccines at any one time. And if you don't believe me, go ahead and look up the pediatrics quote right in there in that article. And I just love the theories they come up with. You know, they have models for their estimates of problems, and then they have theories of how much antigen people can tolerate, and then they never actually look to see what happens in real life. So why is anybody really worried about giving the hepatitis B vaccine to babies? You know, are we all just a bunch of crazy people that have big fantasies and our objections to vaccination, like in this cartoon here that was from a very old anti-vaccine poster? Well, let's take a look at it, okay? Let's look at a little bit of the research that's been done, and you can see if we're all just a bunch of crazies that need to be assigned to the loony bin. So first, this is a publication from 1998 in Pediatrics, and it's by Porcuros. He did 2 studies. And so the objections to vaccinating these little babies is the known fact that that babies have very strong inflammatory responses to the vaccine. All right. So their immune systems can respond. They can respond to infection when they need to, and they will respond to a vaccine, even though that's not what's supposed to be happening in their immune system. So this study here examined 89 premature infants of very low birth weight that were still in the hospital when the 2-month vaccines were due. Okay, so they were just due. So I guess somebody decided to do a little research on them because they were all captured in the hospital system. We don't have data looking at term infants in this way because term babies are at home, and to bring them in and justify to the parents, that they want to enter them in this, it could actually be done, but this is the reason why it's not. Okay. Plus, they don't want to know. So these little premature low birth weight infants received their routine immunizations, so they basically count the number of days out of the womb as their actual age and then go ahead and inject them. And one of the vaccines was the hepatitis B vaccine while these babies were in the neonatal intensive care unit. And then inflammatory markers and adverse events were evaluated afterwards. And what they found was that 30% of infants had apnea, bradycardia, which is low pulse rate, low oxygen saturation, and required ventilation within 12 to 24 hours after the vaccine. And just so you know, these problems often persist for days. So part 2 of this 1998 study was a small targeted observational extension that was designed to explore whether substituting the acellular pertussis component, which is the one we use today, for the whole cell one, which was used in the past, which was supposed to be so much more dangerous, and the acellular one that we use today is supposed to be so much more safe, to see if that would reduce the inflammatory and cardiorespiratory responses that were seen in part 1. And 3 out of 10 of those infants, which equals 30%, developed abnormal cardiorespiratory signs after the simultaneous Haemophilus influenza B, hepatitis B, and polio vaccine, even without the DTaP, the one that's supposed to be so safe. The signs included apnea, again, bradycardia, oxygen desaturation, all occurring within 24 hours. Even without that whole cell or acellular pertussis vaccine. Giving multiple other vaccines simultaneously still triggered cardiorespiratory instability in these infants. So the authors were certain that multiple vaccines given to 2-month-old premature infants stimulated significant reactions in 30%, and that monitoring for 48 hours should be done. And I clipped those comments out of the article to show you there. So next, on slide 28, we have a 2007 study by the same author. And this was a prospective observational study in the neonatal intensive care unit. It was a bit larger. They looked at 239 premature infants who had a gestational age of less than 35 weeks at birth, were most very low birth weight, and all infants were less than 2 months of chronological age, with a mean of 62 to 65 days of age when they were vaccinated. I can't even say immunized anymore. Okay, so next we have some of the results. And 168 infants received either a single vaccine was chosen randomly among the menu of the acellular DTaP, Hib, PCV7, which is pneumococcal, polio, or hepatitis B vaccine. Or the other group received, it was 71 of them, received multiple separate vaccines simultaneously, usually between 2 and 5 vaccines given on the same day. And they tried to blunt some of the reactivity with acetaminophen. I have the clip right there showing you about that, 10 milligrams per kilogram by mouth before the vaccine, and then every 6 hours within the first 48 hours of vaccination. Oh, man. Probably under the guise of making the baby more comfortable, but we all know what this does to the liver, and we know what it does to the immune response, actually. It makes the vaccine probably less likely to be effective, and there are associations with vaccinations and acetaminophen and autism. So remember the last study where the DTaP was supposed to be so much better than the DPT? Well, this is what the authors found. They had C-reactive protein elevations greater than 1.6 milligram per deciliter in 85% of the infants that were given multiple vaccines. Up to 70% of infants given a single vaccine also had elevated CRP, but it varied by vaccine type. There were cardiorespiratory events, including apnea, bradycardia, desaturations requiring intervention within 48 hours. Overall, this occurred in 16% of the infants. 26 of the 39 infants had initiation of oxygen therapy to increase their FiO2. 13 of 39 required bag mask ventilation and initiation of constant positive airway pressure or mechanical ventilation to increase in their already ventilator settings. Oh, man. Okay, so look, you can read here. So cardiorespiratory events were noted in 32% of those who received multiple vaccines. And it's just a nightmare as far as I'm concerned. Can you imagine? So next slide shows that 12 infants had a workup for septicemia after vaccination as directed by the attending physician. These infants had cardiorespiratory events for which intervention was as CPAP, as I showed you, continued positive pressure ventilation, and they also had elevated CRP values. But guess what? And this is usually the case. So after these vaccines are given, the fever develops, and then there's this sudden need to do a complete fever workup in these babies, which is not only expensive, it's invasive, and it's a nasty thing to do to these children. And they usually almost always come up culture negative, and they're always given antibiotics just in case. So here, have a vaccine and have a slew of antibiotics while we stick a lumbar puncture needle into you and do some blood cultures. Oh, just to be sure that we're safe. So then they discontinue the antibiotics between 48 to 72 hours. I mean, just what a slap in the face to these neonates that are already, on the edge of life and death. So the next slide shows that abnormal C-reactive protein values were associated with administration of multiple vaccines with a risk of 15.77. That's like crazy, enormously high, okay? So I've explained this before. If the OR is 1, that means that there was no effect. If it's less than 1, it means that the shots are beneficial. If it's greater than 1, it means it was a problem. It's much greater than 1, 15.77. Oh, man. So cardiorespiratory events were related marginally to multiple vaccines, marginally, 3.62 operative risk, they're calling marginally, and significantly to gastroesophageal reflux. So, all those babies that are refluxing, and it's supposedly from the mother's milk or this or that, and they put them on H2 blockers and, neutralize their stomach acid. Thanks a lot, hepatitis B vaccine. Thanks a lot, other vaccines. Operative risk 4.76. So compared with infants who received a single vaccine, infants who received multiple vaccines were almost 4 times more likely to have immunization-associated cardiorespiratory events and 16 times more likely to have a high CRP value. And the conclusions in the next slide. state, quote, our study revealed that some vaccines, including DTaP, even if administered alone, were associated with cardiorespiratory adverse events and abnormal CRP values in premature infants in the NICU. However, the incidence of these events was higher following simultaneous administration of multiple vaccines compared with administration of a single vaccine. Well, of course, I mean, you don't really need a study to figure that one out, but you have one now. These associated complications are more likely to occur with current practice and simultaneous administration of multiple vaccines. Also, contrary to previous reports, cardiorespiratory events can be observed even if DTaP is given as a single vaccine. Administration of other vaccines given individually, such as the pneumococcal 7 antigen vaccine and Haemophilus influenza B, also can be associated with cardiorespiratory events. All right, so this is why parents and some doctors actually may be concerned about giving multiple vaccines to low birth weight infants, even at 2 months of age, and also may have concern even for term babies, because guess what? The same is true for term babies. They just might not have to be resuscitated quite as much, but they'll still have a total inflammatory storm there. And this is why lots of parents, if they're given half a chance, would refuse a jab to their hours-old infant, especially if they were actually told the real-life risk to the baby of contracting hepatitis B. So here's another study that used large numbers from JAMA Pediatrics in 2015. And this population looked at 13,926 extremely low birth weight infants who received routine vaccinations while still in the NICU. And they compared the 3 days before vaccination to the 3 days after vaccination for each infant. And it was a self-controlled series, you know, kind of that was the design. The same person was their own control. So they got the standard schedule at 2 months of life of chronological age, the acellular DTaP, Haemophilus influenza B, pneumococcal, polio, hepatitis B, et cetera, right? So next slide just shows you the what I just said. And after that, we have a chart that gives you the incidence of events before and after vaccination per 1,000 patient days. Okay, so a sepsis evaluation, the relative risk was 3.5, so you were 3.5 times more likely to require a sepsis evaluation if you got these jabs. What does that mean? Like I just said, lumbar puncture, blood cultures, immediate antibiotics, increased respiratory support, 2.1% higher rates of that. Put in on a ventilator, 1.8 times higher risk of being put on a ventilator. Like, that's no little thing. To put a little premature baby on a ventilator, oh man, you know, their tracheas are so tiny, and it's such a delicate process to put a tube in there. And the chance for a problem with that is actually not zero. Okay, and then during the pre-immunization and post-immunization period, this is a great one here, 5,952 of the 13,926 infants received caffeine therapy. Took a quote right out of there. So 42.7% of those infants received caffeine therapy in the NICU. So, you know, the crash carts are sitting there waiting for something to happen because the NICU staff knows. All right. So there were no pre-immunization deaths, obviously, to compare with, because the dead babies weren't entered in the study. There were no non-vaccinated controls to compare with after the vaccines, but there were 5 deaths in the 3-day post-immunization period. All right. And, you know, surely they would not have been associated with the vaccine, even if they were. And then the next slide has some images, which just shows you, you know, what was going on in terms of respiratory support, sepsis evaluations, and ventilation. And everything was going okay, trending downward. And then, boom, there's a big blip right there after the vaccination series was given. But you're going to love this. Here's the conclusion. Despite all that they saw, And this is why even when you have a study that shows damage, you can't fully rely upon it, because the pro-vax will go, yeah, but they said there was no difference in the incidence of adverse events in combination vaccines versus single-dose vaccines, and that these data provide no evidence to suggest that physicians should not use combination vaccines in extra low birth weight infants. Immunization delay burdens an already fragile patient population with the increased morbidity and mortality of vaccine preventable diseases through the first year. So why even do the study if you get these kind of numbers and this is your conclusion? You already have a foregone conclusion, clearly. I'm surprised they even got it published, or maybe that's why they got it published, because they concluded this in the end. So the rest of us just have to follow the breadcrumbs, I guess. All right. Well, then we have to ask ourselves, what about full-term infants? And these studies aren't as done as commonly as I wish they were, but we do have one study that had a little look at full-term infants after the hepatitis B vaccine. This study was done in Turkey, and it looked at 70 healthy term infants which are given hepatitis B vaccine, and significant increases in CRP levels, C-reactive protein, which is a reflection of significant inflammation, were seen 24 hours after the vaccine. Most infants had elevations in their CRP. 22 of them had CRP levels high enough to mimic the level of sepsis. And you know what that means? I just went through that. So vaccine enthusiasts will just shrug this off and they'll say it's no big deal because, they're clueless, basically, and because they don't care about the organization of the infant immune system, which, as I said earlier, is to be quiescent early on while it's sensing out what is in the world and, as they say, figuring out the world. So remember, that's why infants don't respond to hepatitis B infection, right? During this time, the infant's immune system is quiescent by design while it's figuring out what is dangerous. And as it grows and learns, it naturally becomes more able to healthfully generate inflammation when needed. Like literally every single day will slightly increase that tendency, but it's clamped down. And those clamps are basically removed sequentially. And I go through that in my infant immunity series. But it's not desirable to have that inflammation early on. So hepatitis B vaccine with aluminum interrupts the normal program and development of the infant immune system, and it sets off alarms and inflammation. Because it's not considered important, specific studies looking at later inflammation and autoimmunity are simply not done. And it's funny to me that the first study that I could find that even looks at this issue was done in what year? 2013. And when did they start vaccinating all newborn infants? 1991. Right. Okay, so next, there's another little study here. And unexplained fever in neonates may be associated with hepatitis B vaccine. And they suggest there are more fevers in neonates injected with hepatitis B vaccine, and these babies will undergo unnecessary procedures and treatments to diagnose the problems. And so they're concerned about what I just went through before, that they're immediately given antibiotics, nuking their microbiome, and they'll be given acetaminophen, possibly lumbar puncture, blood cultures. They'll be screaming, yelling their heads off, a huge amount of stress. And why? Why is all this being done? Because you gave a hepatitis B vaccine to a low-risk baby that literally had no risk of developing hepatitis B because the low-risk mother tested negative. It's hard to maintain my composure. So the next one is looking at mice. And mice are given vaccine-relevant doses of hepatitis B vaccine as neonates in this study, and they developed neurobehavioral impairments in early adulthood. But guess what? This article will just be ignored. Why? Because it's done on mice. Because mouse studies only matter when you're promoting a vaccine, not when you're trying to show damage from vaccines, right? Because we're not mice. So here's what you'll be told by the ACIP and the general so-called authorities if you ask why no placebo-controlled studies were done early on before deciding to inject newborns with hepatitis B vaccines. You will be told that true placebo-controlled, randomized controlled trials of hepatitis B alone at birth in low-risk general population infants are rare and non-existent due to practical reasons once efficacy was established. I put the word supposedly in there, okay? If you don't know, there are no saline placebo-controlled studies looking at the hepatitis B vaccine risks given to day-old newborns. Why is that? Well, it's because the recombinant hepatitis B vaccines, the ones that we're using today, were licensed based on immunogenicity, which is antibody response, and some short-term safety monitoring for a few days in some uber healthy infants in a small group, not a large group of premature low birth weight infants for sure, and comparisons that sometimes used aluminum-containing placebos or other controls rather than pure saline. And we know that this is a common practice, habit, whatever you want to call it, by supposed vaccine scientists to use another vaccine that contains an inflammatory agent for two reasons, they say, because it will make it less obvious who received the placebo. And the other reason is that, we don't want to deprive the placebo group from something beneficial. I mean, what a riot. So we're told that it's unethical to do a saline placebo study now because the safety was long ago established. So let's decide for ourselves if the safety was really long ago established. So I have this book here. And remember how I just said that no placebo-controlled studies exist because the safety was long ago established? Well, this book right here was published in 1994 and was supposed to be an accurate reflection of real-world adverse events associated with childhood vaccines. And note that they don't use the word caused ever. They only use the word associated, okay? So let's have another look at the history of this book and where it came from. So I want to tell you how the dogma becomes the vaccine in infants was proven safe overseas, even when it wasn't. So the next slide, please. So back in 1988, a memorandum from the head office of the Department of Health in New Zealand's capital was sent to the health boards of all hospitals stating that the side effects of the hepatitis B shot were mimicking serious health conditions, and so as to not confuse the diagnostic picture, that hepatitis B vaccine to newborns should only be given to babies from known hepatitis B positive mothers. And aside from that the injection should wait until the infant was about to be discharged home and not on the day of birth. And that the shot should only be given to healthy and thriving babies. Any infection should delay the injection, and also that caution should be exercised when administering the shot to babies with severely compromised cardiopulmonary status or when febrile reactions caused by the vaccine could pose a risk to the child. Now, remember that study I just showed you before? Some of those babies were actually on a ventilator when they were given all their vaccines. So in this particular recommendation, that baby would not have been touched with a vaccine. And if there was any doubt, the vaccine, they say it right here in the letter, the vaccine should be even further delayed until the first pediatric visit at 6 weeks. So you know that these doctors and these health boards saw some significant events in these babies after the shot was introduced on the day of birth, and they were none too happy about it. And so next, we see that this was followed on the 17th of May by another very detailed handwritten letter. But it was initially handwritten. I actually have all the originals of everything I'm talking about here. Okay, and then it was later typed up from the head office in New Zealand's capital of Wellington. And then on the 28th of May, the Ministry of Health specifically warned all and sundry about the two most serious problems of concern in this memorandum: allergic reactions and urticaria. And they warned doctors to not vaccinate anyone who had an allergic reaction, and that with urticaria, any subsequent vaccines should be given in a hospital setting. So again, they're concerned about this. So next is another document, analysis of adverse events reported after hepatitis B vaccination in preschool children. So what sorts of reactions were seen? For newborns, that was kept private, okay? But for preschoolers, there was a count from March to September 1988, looking at 166,757 children who got at least one hepatitis B shot, and 1.34% of them were accepted, into the stringent criteria that they had as having a relevant event that made this list. For the purpose of this discussion and the corruption that I'm about to tell you about, let's focus on the anaphylactic and anaphylactoid reactions. So next we see the number of specific events. Urticaria, 107. Asthma or bronchospasm, 70. Swelling or edema or angioedema, 47. Anaphylaxis, 2. Death, 2. So here's how the dogma gets changed to, quote, the vaccine was proven safe in early trials. They just roll over anyone who finds the damage. So 2 boys had significant anaphylaxis, as you see in the next slide. But all's well that ends well, they say, because adrenaline saved the day. Next, death. 2 deaths were not considered relevant. Why? Because SIDS apparently has an expected rate, which they said should have actually been 5.5 and not 2, according to their modeling. So I guess we can assume that the hepatitis B vaccine prevented 3.5 instances of SIDS. Well done, hepatitis B vaccine. Right. Okay, I'm joking for anyone out there who's got Asperger's. But here's the real rub. The New Zealand professionals who furnished the editor of this book with data on anaphylaxis expected their information to have been reported, but instead, if you see the next slide, if you turn and you open page 229 of the book, you will see a quote, anaphylaxis was not observed in the 166,757 children vaccinated. Remember in the last talk I gave on the meningitis vaccines, and I gave you the information on how the safety was supposedly measured and accepted on the meningitis B vaccines that are used in the USA and the UK today was based on trials that were done in New Zealand on what was called the MENZB and MENZB vaccine, which was a vaccine that was repurposed out of Norway. And I showed you all the corruption. I showed you the 12 deaths that happened only in the vaccinated side of the study, not in the non-vaccinated side. And yet that vaccine it was released. It was continued for a period of time. And then they stopped it because there was so much outrage and upset among the general population who had subjected subjected their babies to 4 of these injections, only to realize that it did nothing in terms of stopping the meningitis. And later, this same vaccine was adopted worldwide because it was supposedly proven so safe. So that was in the meningitis talk, if you want to go and have a look at that. So just like that, being the foundation for the meningococcal vaccines that are given today all over the world being a lie, so is this report from the Institute of Medicine regarding the hepatitis B vaccine and anaphylaxis a blatant lie. It's water under the bridge now, though, isn't it? And it was water under the bridge pretty quickly, even after this occurred, because the New Zealanders who presented the information, in the next slide, to the IOM followed up, reminding them of the 2 well-documented anaphylaxis cases, in addition to the May 1988 caution letter sent to all medical boards due to the fact that there were 10 reports of anaphylactoid reactions in children after hepatitis B vaccines, and that a guy named Professor Ralph Edwards reported another 14 cases since 1985, and that there was so much concern among medical professionals that the vaccination policy in hospital settings was changed and delayed or not given at all until 6 weeks of age. The communication to the editor of the IOM book was basically ignored for 3 entire years, upon which she finally responded, because there were several prompts to her, and she finally responded stating that the report was final and cannot be changed. So I want you all to remember this when you hear that safety was monitored in post-marketing surveillance. In this case, the Institute of Medicine's gold standard book, this, falsely represented the real-world events. So right around this time in the USA, babies were consigned to being pricked within hours after they entered the world, whether their mothers were hepatitis B positive or not. Okay? That's how it works. So it goes on from here, what happened in New Zealand, because there were some doctors who, they were really seasoned GPs in New Zealand, and they noted the difference between what babies looked like before that vaccine started to be given at birth and what it looked like afterwards in their general practices. And what they noted was that they were giving more antibiotics since this vaccine was started, that they were seeing more immune system derangements, and that they were absolutely seeing more jaundice in newborns, and not just the regular old type of jaundice that they used to see, but a jaundice that could sometimes last for 2 to 3 weeks. And I have these paper right here. Yeah, the whole letter, very eloquently stated about their concerns, and that they didn't think that this was a really good idea to be doing this vaccine at birth. All right, so next we're just talking about jaundice, and so I asked the question: has anybody done a study looking at non-vaccinated newborns versus vaccinated newborns to compare jaundice rates? And I'm told no. There are no published studies that directly compare jaundice, hyperbilirubinemia, when the baby turns yellow when it's put under a blue light, which actually gets rid of the jaundice, but actually doesn't really help the baby because that jaundice is actually trying to take care of the inflammation that's gone on, and everything is bass-backwards in this world. That the bilirubin levels between hepatitis B vaccinated and unvaccinated newborns in a controlled manner has not been looked at. Okay? So if anybody wants to tell you that it's perfectly safe, that this vaccine isn't going to turn your baby yellow and it's not going to be a problem and they're not going to require sepsis workup and they're not going to require antibiotics afterwards or caffeine therapy or intubation or resuscitation or anything like that, you can now know that that is a complete lie. All right, so let's look at some more relevant research on hepatitis B vaccine safety. That I've used these slides in the past, and I just want to go through them again with you because these actually are also relevant studies in a world where let's just say that the downside to vaccinating is usually noted by accident or as a secondary notation in a study that was looking at something else, but that it's not really usually how the studies are designed or why they're designed that way. So let's look at this first one here by Hamza in 2012. And so what they did here is that they injected mice with human relevant doses of the hepatitis B vaccine, meaning weight for weight, pound for pound. So one group with 1 dose and another with 2 doses, and then compared them to a control group of mice. And they analyzed the gene expression changes in the liver on day 1 and day 7 after the vaccine was given using something called microarray technology. And it says in the article that the hepatitis B vaccines have several side effects that are caused by the aluminum adjuvant. We confirmed by the quantitative RT-PCR that hepatitis B vaccine changed the expression level of 7 genes that were selected biomarkers, which reflected some toxic/adverse effects of the vaccine, especially subtle liver injury. Next. Mice injected with the hepatitis B vaccine, 144 liver genes changed after the first day, 52 were downregulated, 92 were upregulated, and then 7 of those were closely examined. And they noted that 2 inflammation genes were upregulated, 2 acute phase inflammation proteins were upregulated, 1 for gluconeogenesis was upregulated. That's the ability of your body to manufacture its own glucose when it's starving. And 2 for bile acid synthesis were downregulated. So they concluded that vaccination altered certain gene expressions and highlighted potential areas for further safety investigation, right? Well, we know that even just doing that can get people in trouble, like it did with Andy Wakefield. And so the next slide, I said, oh, well, that's really interesting. Hey, Grok, my buddy, they concluded that vaccination altered certain gene expressions, highlighting potential areas for further safety investigation. But those studies are never done, are they, Grok? And he said, no, exact follow-up studies replicating the Hamza 2012 mouse liver gene expression experiment in human-term infants have not been done, because any doubts, whether or not well-founded, about the safety of the vaccine must not be allowed to exist. All right, so we have another one from Garley in 2004. And this is an observational cohort study from a high mortality, low income setting in West Africa. in Guinea-Bissau. And they examined potential non-specific effects of the hepatitis B vaccine on child mortality with a focus on sex differences. 6,399 children got a measles vaccine. 876 children got a measles vaccine and 3 doses of hepatitis B vaccine. They were followed to 2 years of age. Measles vaccine only, but no hepatitis B vaccine. That group had a mortality risk of 0.97, meaning that the measles vaccine actually had a slight improvement, showed a slight improvement in mortality risk, very slight, 0.3. If they were given hepatitis B vaccine plus measles virus, compared to this group that was given the measles vaccine virus only, at 7.5 months, short-term mortality risk, 1.62. Okay, so 1.62 higher likelihood of dying if you were given that hepatitis B vaccine in addition to the measles vaccine. So even any potentially beneficial effect of the measles vaccine was obliterated by this. At 7.5 to 12 months, the mortality risk was 1.81. And the female to male ratio was 2.20. So females were dying more than males in this particular study. So next slide has a quote right out of the article. The vaccine is given in infancy, and there has been no evaluation of its effect on mortality among young children. Because trials would now be considered unethical, any evaluation must be based on observational studies. So there you have it right there. These researchers know that once a vaccine is licensed, that you are then not allowed to do trials, especially placebo-controlled trials, because it's considered unethical to withdraw a vaccine that has so much shown benefit, even if it doesn't. And Peter Abe also noted similar problems when he saw the DTP shot killing babies in Africa as well. That once a vaccine is on the schedule, it's almost impossible to remove. And we're seeing that with hepatitis B vaccine, which we'll get to in a minute, the politics of that. So let's look at another study, Coberly, 1996. I'll give you all the PMID numbers. You can go onto PubMed and look yourself. So what did this study look at? They had 225 healthy infants born to hepatitis B negative mothers, and they were randomized into 3 groups at 2, 4, and 6 months of age. And so what they were really looking at here was different routes of administration of the hepatitis B vaccine and different doses. So one group got an intradermal dose of 2 micrograms, another one got intramuscular 2 micrograms, another one got intramuscular 10 micrograms. And then they measured the antibody response after the series to see how well the vaccine worked. And that was essentially the purpose of this study. But what they also happened to have noticed is that the infants who received the standard, which is what we do today, 10 microgram doses, had statistically significant growth retardation. They considered this a non-specific effect. And so growth and weight data before and after is almost never reported in infant vaccine studies. But in this one, they happen to have looked at it. But since the primary focus of the study was just looking at antibody response, not safety or growth, this result is blown off as insignificant, and it's largely ignored. And 10 micrograms is the standard dose today, though today most countries use the recombinant vaccine, not the same exact vaccine that was used here, but the dose is still 10 micrograms. So you can take that for what it's worth. All right, so there's this phenomenon called vaccine viral escape. And I also want to talk about the new vaccines that will be available in the future because of this vaccine viral escape issue, as well as other nonsense reasons. And I'm just going to flash these slides up, and then people can go back later if they're interested in vaccine viral escape. I don't want to go through every single one. I just want to say that vaccine viral escape is a real thing, just like with the measles vaccine. Eventually, it took a long time, but that the measles circulating in the population, some of it has now become resistant to the vaccine, so that if you're vaccinated, you can still get it. Well, the same thing has also happened with the hepatitis B, and the same thing has also happened with the pertussis bacteria. really bad with the pertussis bacteria. Not quite as severe with the hepatitis B, but it's still something that happens. And it says here in this slide, under selective pressure from the host immune response and or antiviral therapy, viruses with mutations emerge as the dominant viral population. Next slide says, this permits selection of mutated hepatitis B virus by host immunity and antiviral therapy. A number of well-characterized HBV mutations have been recognized, leading to vaccine failure, loss of HBV detection by diagnostic assays, increased viral replication leading to hepatic damage, and resistance to antiviral agents. So, the more vaccines you give, the more likely you are to be causing this phenomenon. So after 1991, I think that we would have seen this problem ramping up even more. So that publication was from 2011. Slide 68 there is showing us another one from 2007. Again, just talking about hepatitis B virus escape mutants. And I'll just take one quote from the next slide here. Occult infections began to be noted in the late 1980s, and the first case of vaccine-induced escape mutant in a child in southern Italy who received passive active post-exposure immunization was described in 1990. Occult infections create public health concerns because asymptomatic carriers can be blood donors. These mutations are stable and can be transmitted horizontally and vertically. So while they can celebrate that they have decreased some infections, they have actually started a whole new problem. Okay. Slide 70, research with child vaccination shows that mutations accumulate with higher frequency in vaccinated than unvaccinated children. This is something that nobody ever talks about, do they? The AAP isn't bringing this up. Vaccinated children generated a preferential accumulation of mutations in the second loop, while unvaccinated children generated random mutations. And this is the same with all the vaccines for which vaccine escape has been noted. So the public is told that escape mutants are real, as you can see in the next slide, and that they constitute about 6 to 18% of the cases. They are more noted in the high vaccination settings and cause diagnostic issues because the hepatitis B surface antigen tests can then become false negative. So how many of those cases that we are told went down to zero because there's a vaccine virus escape and the test is a false negative? They go on to say that the issue highlights the value of sustained high vaccination coverage, improved diagnostics, and potential next generation vaccines. Always next generation vaccines. So when they get themselves in trouble over their past crimes, what do? They come up with new vaccines, vaccinate more and more and more and more and more. We've seen it with polio. We've seen it with measles. We're seeing it with pneumococcus. We've seen it now with hepatitis B. And when it comes to some of these vaccines that have, say, 7 antigens in them, then they increase it to 13 antigens, and then they increase it to 23 antigens. I covered this all in my talk called The Whack-A-Mole Vaccine Game, where you can celebrate that you decreased invasive infections by certain bacteria using your vaccines, but then invasive infections from other bacteria have increased as a result of the selection pressure. All right, so in slide 72, while we're told that there's no big deal to the vaccine escape mutant issue that has been noted since the 1980s, we are also told that there are new vaccines on the market in parts of the world and that the old hepatitis B surface antigen vaccines will be replaced. And here you can see the next generation HBV aim to overcome limitations of standard second generation recombinant vaccines. Those are the ones we use today, which contain only small surface antigen produced in yeast. These limitations include non-response in 5 to 15% of people, reduced effectiveness against some vaccine escape mutants, and the need for more doses or stronger responses in certain populations. Yeah, like my dialysis populations and people who are just non-responders. So will this work? I don't know. Will it be toxic? Probably. Guess what? Not only were 7 million children injected with mRNA vaccines in the past year in the USA, despite the fact that they never needed it, but messenger RNA vaccines are coming around regarding hepatitis B as well. And here you can see that the preclinical lipid nanoparticle messenger RNA vaccines encoding the hepatitis B induce stronger antibody and T cell responses than the old vaccines, with potential for better breadth. However, these remain early stage and not yet optimized or tested specifically for vaccine escape mutants in humans. So this was published in 2025. So I really now wonder if they will be deemed safe for newborns and 6-week-old babies based on the same type of reporting that we saw in New Zealand, or whether it'll just be all whitewashed and you'll be told that everything's great and that the rate has gone down to zero, and that maybe some of that zero might be an effect of their tests no longer being valid because they're a viral escape. I mean, you get the big picture now, I hope. The ACIP stopped recommending the hepatitis B vaccine at birth. And we also know that the AAP continues to defy that recommendation, that many doctors, vigilante nurses, et cetera, are still defying that recommendation, despite everything that I just told you that they have no clue about whatsoever, because they believe the sound bites, vaccines are safe and effective. And, you know, you have to give this to your baby. So give her the strongest shield, lifelong shield. So many doctors and hospitals are not following the new ACIP CDC recommendations, and practices vary significantly. They are continuing to strongly recommend the birth dose of hepatitis B vaccine. Why? You have to ask yourself, why now? Is it corruption? Is it stupidity? Is it ignorance? Is it that their bank accounts can't afford to say no to it? Is it because they have to exert dominance over their patients and label them as anti-vax conspiracy theorists if they don't want a formaldehyde and aluminum-containing vaccine given to their 6-hour-old baby? Or might there be something to it that we just went through in 74 images with fully backed research? You be the judge.
That's excellent. This presentation should go to every single medical school in the world. And if you still think it's a good idea to have the hepatitis B vaccine for your newborn or your premature baby after watching this presentation, then I think there's no hope for you.
You should be committed. You should literally be locked up and, never allowed to interact with a child or an infant.
Yeah.
But instead, what we have is vigilante nurses taking the baby out away from the parents and jabbing them and then bragging about it online.
Right, and calling CPS. Now, listen, here's my advice. Mother to mother, okay, is do not give birth in a hospital. You don't need to give birth in a hospital. Give birth at home with a holistic midwife, and that all of this will go away. We've seen it; it's happening all over the country right now as we speak. And like I say, find a really good midwife. Find a good godmother as well while you're at it. Find a good midwife.
Find God while you're at it.
Find God. Find a good midwife and give birth at home. It's what we used to do, and it takes away all this pressure of these crazy people. Because the minute you go in there with that pregnant body, that baby becomes property of them, or that's what they want you to believe. But it's that the bullying we heard on the bus about hepatitis B was unbelievable.
Yeah. So, when you think about it, you know, hospital birth has really only been a thing maybe from the 1940s onwards. It's not even been 100 years of humanity on Earth where people decided that that pregnancy is a disease that needs to be managed in a hospital by men who absolutely know nothing about midwifery. Whereas before that, we had thousands of years. Were there instances where there might be placenta previa and the baby and the mother died? Yes, there were. And those are the times, that is the only reason why perhaps you might want to have a C-section or think about doing something in a hospital. But the thing is, a good midwife can detect that. It's apparently quite obvious to a good midwife if there's placenta previa, if there's a breech. But breech births can also be done at home. I mean, I saw breech births being delivered in Nicaragua by the most calm. They were midwives. They're basically community people that were trained. And so this idea that there's all these specific circumstances where you don't want to have your baby, you know, at home because it's so dangerous. I think when you look at today's world and what they're doing to these babies shortly after birth and the stress they're putting the mother under, the positions they're putting the mother into when giving birth, I agree with you 100%. It's an absolute no-brainer to do everything you can to get the support around you to have that baby at home. And also, Polly, like talk to people like Bella, because I think Bella probably talked to people that had given birth at home and they had a very calm demeanor about it all, because that's really important to have that kind of mindset in your in the foreground of what you're thinking, rather than going online and looking at all the potential problems that could happen when you're giving birth at home. When the fact of the matter is that most people that give birth at home, like nearly 100%, do really well. Yes, sometimes there might be an instance that afterwards you might have to go to the hospital for some fluids or something like that, or they might, there might be some problem with the baby. But that's, again, super, super, super rare. And it's still always an option if things don't go well at home.
That's quite right, Dr. Suzanne Humphries. Well, listen, you've been talking for long enough, and thank you so much for that very long, thorough presentation. And again, this presentation should be sent to absolutely every new parent. Send it to your doctor. Send it everywhere, because everyone needs to see this. In fact, HHS, we must send it straight to HHS.
Yeah, I'm sure they love me there.
I'm sure they do. Why would they not? So yeah,
They don't really. They don't. Even though we have some really good people in there, they don't tend to take well to people who tell the absolute solid truth about vaccination. And I think we did that today. I think you can make a case for taking on some measures to really, really high risk situations, but the vast majority, as in 99.5% of infants being born, don't need this shot. So don't we have to ask ourselves why they're pushing it so hard? Like, what's the deal here?
No, and again, we've seen all the harm that can come to you if you take that shot. And I can't believe that a 4-pound premature baby is given that, and vitamin K as well. It's absolutely disgusting. I'm surprised they even survive, and most probably don't. And then they'll just say, well, it was premature, it was going to die anyway. And you were right about the crash carts, bringing those up. We had someone on the bus tell us that they line up the crash carts because they know that they're all going to crash and it's going to be disastrous once they're given this baby. So my advice, seriously, stay away from hospitals. You don't need to be in hospital. I think I'm probably the only person that can give that advice. And these views are not necessarily the views of Children's Health Defence, by the way. Just in case you're interested. Dr. Suzanne, thank you so much for your amazing research on that, and more to come, everybody. But we'll be dissecting that and getting it out on social media as well, so you can share away. But thank you so much, Dr. Suzanne Humphries.
Thanks. Okay. Have a great day. Bye.